Good morning, everybody. Today, what we are going to see is the initial part of fetal echo. So what we will do is we will have a session every month on fetal echo and learn it bit by bit. So today we are going to have indications for fetal echo. When we see indications, it means that on whom do we do fetal echo and when do we do fetal echo. What we are going to cover in today's topic is why to do a fetal echo, when to do the timing, whom indications, the yield of fetal echo, and whether fetal echo can be done for only selected high-risk group cases. That means it's a targeted approach, or can it be done for every single pregnant woman. First, most important is to understand that what is the role of fetal echo. Now, we know that the incidence of congenital heart disease is approximately 16,000 live births if we include every single CHD, including the minor ones. And this incidence is 6.5 times more than the chromosomal anomalies and 4 times more than the neural tube defects. That means that it is a huge number, and it accounts for 30% of neonatal deaths which happen due to congenital defects. It is also a significant contributor to infant mortality, and hence the burden of congenital heart disease is significant. Now, what happens is if we pick them up after birth, we understand that lots of critical congenital heart diseases can give a pediatrician a normal examination at birth. The first 48 hours, the baby can behave normally, and hence it has been found that 25% of the newborns with congenital complex heart disease go home undiagnosed, and then they present a week, 10 days later in a critical situation where intervention still may not be beneficial to a significant extent, and hence the effort of picking them in fetal life. And hence fetal echo contributes to some extent in picking up these babies earlier, where we can manage them in a timely way. The prenatal diagnosis of congenital heart disease is known to help in certain congenital heart diseases, predominantly the ones which are critical. That means that we have a ductal dependent systemic circulation like hypoplastic left heart or coarctation, ductal dependent pulmonary circulation like pulmonary atresia, or when we have failure of mixing like transposition of great arteries. So in these situations, prenatal detection does help in reducing the perinatal mortality. In addition to that, arrhythmias do have a possibility of intervention during pregnancy and postnatally, and these babies do wonderfully after birth. So understanding that the fetal echo does help us in reducing the morbidity and mortality of congenital heart disease, now we need to understand what is the time of fetal echo. Now, in general, we know that by 6 weeks, the motion of the fetal heart is seen. However, it's too early for us to understand anything in terms of structure or function. By 16 weeks, we can do a satisfactory structural analysis. So usually it is the 18 to 24 weeks time where a fetal echo is recommended. After 24 weeks, what happens is we have calcifications of the ribs and the spine, and also the fluid component comes down, because of which visualization of the baby's heart becomes difficult. And hence the general understanding is we prefer second trimester. However, in our country, because we know that 20 weeks is the legal age of termination, we usually prefer 16 to 20 weeks as an ideal age for fetal echo. Now, in general, though we know that fetal echo is ideally done before 20 weeks, most of the references happen after 20 weeks. One of the reasons is because the anomaly scans are done usually by 22 to 24 weeks. And hence, when anything abnormal is picked up in an anomaly scan, the reference happens much later, usually by the end of second trimester or beginning of third trimester. So the message is 16 to 20 weeks is an ideal age for doing a fetal echo. But sometimes we do it in the first trimester. So what are the situations where it should be done in the first trimester? There are parents who have the first baby with a complex congenital heart disease like hypoplastic left heart, where the first trimester fetal echo is indicated, or sometimes during the NT scan at 12 weeks, if they find anything which is not normal, like an abnormal ductus venosus Doppler or tricuspid regurgitation which is more than mild. So as you can see in this figure, this is a Doppler of ductus venosus, and ductus venosus is like any other venous tracing with a negative wave which is normally not so prominent. So if you have a prominent A wave in the ductus venosus Doppler, or you have AV valve regurgitation, tricuspid regurgitation which is more than mild, it typically points to an associated genetic problem with or without a congenital heart disease. And hence, we either do a transvaginal or a transabdominal scan in the first trimester. The understanding is, even if the scan is normal, we need a repeat scan before 20 weeks for completing the understanding. So what is done in the first trimester is sort of a screening fetal echo to make sure that we do not have a complex problem, especially in the fourth chambered heart and the great vessels. So the fourth chamber and the great vessels need to be seen in the first trimester for high-risk mothers, and also when the ductus venosus Doppler is abnormal or there is presence of tricuspid regurgitation. There are situations where we would repeat imaging. So though it is done in 16 to 20 weeks of gestation, there are situations where we need to repeat the scan. The most important is arrhythmias, which includes brady and tachy. If the mother is having ROLA antibodies positive, then even if the second trimester scan is normal, we do repeat the scans for PR interval so that we understand if the baby is developing second degree or complete heart block. If the baby has a tachyarrhythmia, which is transient also, we keep repeating scans to see if it becomes persistent or we have development of heart failure or hydrops. The second important understanding, as we said, is maternal autoimmune disease, where once in two weeks scans should be repeated till the baby gets delivered. Heart block can develop during pregnancy. Third important is semilunar valve stenosis. If you have an aortic valve or pulmonary valve narrowing, this stenosis can worsen during pregnancy, or the valve can be completely atratic by the time the baby gets delivered. So these things can change during pregnancy and needs a follow-up in general until 4 weeks of pregnancy. AV valve regurgitation, anything more than mild tricuspid regurgitation, or if it's a hollow systolic, if it's throughout the systolic tricuspid regurgitation, it needs to be monitored, and also mitral regurgitation. Both these things can worsen during pregnancy. Also important understanding is the ventricular compliance is not normal during fetal life, and the ventricles are more stiff, unlike what we have it in children, because of which any AV valve regurgitation or even semilunar valve regurgitation cannot be well tolerated with the fetal heart, and they tend to develop heart failure much faster during fetal life, and hence they need multiple scans during pregnancy. Ventricular disproportion. That means that if one of the ventricle does not look normal size, either the right heart is a little more dilated compared to what we accept during pregnancy. Normally during pregnancy, the right heart either should be equal or a little more dominant than the left heart. So if the right heart looks more dominant than what we are comfortable accepting it, then we need a follow-up to understand whether are we going towards development of hypoplastic left heart or not. So these are few conditions where we need to image repeatedly, sometimes once in a week to sometimes once in 4 weeks till the baby gets delivered. So this is regarding the timing. The next understanding is, when do we do a fetal echo? So there are a list of indications which are proposed by different organizations, and this list has kept on changing over the last few years. However, the latest recommendation says that we have few maternal indications, few fetal indications, and few familial indications. We'll first of all go to the familial indications. That means if there is something significant in the family history, then it's an indication for fetal echo. The most important would be either a maternal or a paternal. Maternal, we have taken it as separate list of indications, but paternal congenital heart disease is also an indication. If the first child or the previous children had congenital heart disease, then it's an indication for fetal echo. And if there is a family history of certain syndromes or gene defects, then also it's an indication for fetal echo. We will go through individual indications in detail in the subsequent slides. Amongst maternal indications, maternal congenital heart disease is an indication. In addition to that, if the mother has diseases like diabetes mellitus or autoimmune diseases like systemic lupus erythematosus or Sjogren's disease or phenylketonuria, then we need to recommend a fetal echo. If the mother is exposed to certain teratogens or has had history of infections or even for IVF conception. So in vitro fertilization is an indication for fetal echo. Coming down to the list of fetal indications, the most important is an abnormal cardiac screen. That means that during the anomaly scan, if the radiologist feels that there is something wrong with the heart, this is an indication for a fetal echo, and we will see in subsequent slides that this is a very important indication and a very good way to pick up congenital heart diseases during pregnancy. The second is if the nuchal translucency is increased either during the first trimester. By 14 to 15 weeks, if the NT scan says that the NT is increased, then it needs a fetal echo. Presence of extracardiac anomalies or chromosomal anomalies also needs a detailed fetal echo. There are certain conditions where there is risk of congestive heart failure where a detailed fetal echo is recommended. Any evidence of hydrops fetalis, whether it is cardiac or non-cardiac hydrops, needs a understanding of the heart. Twinning, any twin pregnancy. That means that in the recent era, we have increase in the incidence of in vitro fertilization and also multiple pregnancies, and hence the need for fetal echo in both these situations. Fetal arrhythmias, if any irregularity in the rhythm has been picked up during the anomaly scan or even later during the growth scans. And the last is polyhydramnios. So these are the list of indications for fetal echo. Very interestingly, echogenic focus, which is actually in fact still a very common indication for fetal echo, is not in the list now. It used to be in the list before, but echogenic focus is not in the list now. Echogenic focus, if it's in a single ventricle, can be present in 6% of normal pregnancies. And if it's in both the ventricles, the incidence of congenital heart disease is a shade higher than general population. So now we will look into a little bit more of individual indications. Family history, if it is maternal or paternal, or we have a previous child or a fetus with CHD. Fetus with CHD means that the fetal echo in the previous pregnancy showed a fetal echo, and after that the baby did not survive till birth, either aborted or terminated. The recurrence risk is very important to understand for us. As we said initially, that the general incidence of congenital heart disease is 16,000, which makes it 0.6 in 100, 0.6%. So if one previous child is affected, it becomes 2%. It's still not a very big percentage. That means that we have more than 95% chances of having a second baby without heart disease. This is important when we counsel the parents when they plan for a second pregnancy. And if we have two previously affected children, then the incidence becomes 10%, which is much higher. And hence, in a family where we have two children with a heart disease, the incidence goes up significantly higher. Whenever we have a family history and we do a fetal echo, the biggest benefit is, if it's normal, the reassurance to the couple is invaluable. Also, the incidence of recurrence or the recurrence risk varies with the type of the heart disease the previous baby had. Very important to understand, the left-sided heart lesions have a significantly higher incidence compared to the overall incidence. As we see here, 2% is one previously affected child. But if it's left-sided heart lesions, including causation, the incidence goes up to 7%. Complex congenital heart disease in general, single ventricles, transpositions, Hypoplastic left hearts, right hearts, they have an incidence up to 10% even if one baby is affected, and also truncus arteriosus close to 8%. Hence, the recurrence risk is higher for heterotrachees and hypoplastic left hearts compared to the usual recurrence risk. The second component is if there is a family history of inherited disorders or single gene defects. Now, in this we have a list of defects. The most important would be a Dye-George syndrome as a pediatric cardiologist, Marfan's and Noonan syndrome, even Ellisville-Crevell syndrome, which commonly has an AV septal defect, and Holt-Oram with an ASD, tuberous sclerosis with rhabdomyomas. So I think most important would be a Dye-George, Marfan's, and Noonan's. These syndromes are very commonly seen with babies with cardiac defects, and it's important to understand that in that situation, get a detailed genetic consult before the plan for next pregnancy, or get a fetal echo done if the mother is pregnant. Metabolic disorders. If the mother has diabetes mellitus, it's important to get this information, whether was it during the first trimester or did it come second trimester onwards. Because if it happens during the periconceptional period and the mother has higher HbA1c, then the incidence of congenital heart disease is 3 to 5 times higher compared to general population. The commonly known CHD is a TGA when the mother has diabetes mellitus. If the diabetes mellitus comes during second or third trimester, a direct correlation has been found with the hypertrophy of the ventricles, and this is something which is completely reversible postnatally, usually within 6 months after delivery. The yield is 0 to 7%. Yield means if the mother has diabetes and we do a fetal echo, the chances of finding a congenital heart disease is up to 7%. This is especially when the mother had diabetes in the periconceptional period. Overall, the control of diabetes also has a direct correlation, and hence the emphasis on control of diabetes during pregnancy is important. The second most important is the autoimmune disease in mother, which commonly includes the systemic lupus erythematosus and Sjogren's syndrome. Maternal autoantibodies, especially the NT-Rho and NT-La, can cross the placenta usually around 16 to 18 weeks and can cause heart block and also cardiomyopathy in 1 to 3% cases. So it's important to understand that many of these mothers are asymptomatic, but however, if the mother is found to have antibodies positive, then serial monitoring of PR interval would be important during pregnancy. The most commonest time to cross the placenta is usually end of second trimester or mid-second trimester. In addition to PR interval monitoring, they could develop cardiomyopathy in terms of ventricular dysfunction, effusions, etc. And the incidence is up to 3%, but monitoring of every single lady with antibodies positive is important. Once we find that they have developed a first or a second degree heart block, then the management could differ because the benefit of giving steroids during pregnancy is there till second degree heart block. Once they have established complete heart block, most of these heart blocks are irreversible and steroids do not make a difference in terms of reversibility to sinus rhythm. Exposure to drugs like anticonvulsants, phenytoin, lithium, NSAIDs and retinoids can cause heart defects, and these viral infections, commonly rubella, CMV, parvovirus, can cause effect on the baby's heart. It's not only that we are looking at structural heart defects like with rubella or with NSAIDs or with anticonvulsants, but these infections and certain medications can also cause myocarditis. NSAIDs sometimes used during pregnancy can also cause premature ductal closure. A very important understanding especially happens during third trimester when aspirin is on, and the effect seen is in terms of premature ductal closure where the right heart shows dilatation and dysfunction and regurgitation of tricuspid valves and pulmonary valves. Stoppage of aspirin usually makes it reversible in the sense that the changes are reversed and the duct can open up. This is something which is important and very valuable understanding because it's reversible. Sometimes it may need premature delivery. Nuchal translucency. So NT is commonly measured by 14 to 16 weeks, 14 to 15 weeks of pregnancy, and any number which is more than 3.5 millimeters says that there is significantly higher incidence of congenital heart disease, and it can help in increasing the detection rate of the cardiac defects even in normal chromosomal euploid fetuses. Presence of extra cardiac anomalies has a direct correlation with congenital heart disease. Now, presence of an extracardiac anomaly increases the risk up to 45% for a congenital heart disease. However, there is an organ-specific risk also found when a renal anomaly is detected. Half of these babies tend to have cardiac problems, and if there is a CNS malformation, 5% of these babies tend to have a CHD. So during an anomaly scan, if any of these extracardiac anomalies are found directly, it's an indication for a fetal echo. Common extracardiac anomalies which are having a direct correlation with congenital heart disease includes most important would be omphalocele, and a commonest defect which is found is tetralogy of Fallot. Also diaphragmatic hernia, tracheoesophageal fistula, and duodenal atresia. Single umbilical artery is an indication. 45% of these babies tend to have congenital heart defects, and also babies with polyhydramnios. Presence of chromosomal anomalies. If it is suspected, again, it accounts for 30 to 50% contribution to congenital heart disease, and most common correlation is found with 22q11 deletion and trisomies 21, 13, and 18. The other way, if a congenital heart disease is found, there is a risk of chromosomal abnormality up to 15%. However, individual congenital heart disease also has a different association, where atrioventricular septal defect is found to have a maximum correlation with CHDs and extracardiac anomalies. And there are certain congenital heart diseases like transpositions, the DTGs and even CTGs, that means corrected and complete transpositions. They have a least association with chromosomal anomalies. There are conditions where we know that there is a risk for heart failure, which includes one most important is absence of ductus venosus. So as we understand the role of ductus venosus, what happens if it's not there? It can cause cardiac failure. If there is a systemic AV malformation or a vascular tumor, it can contribute to the load and cause cardiac failure. As we understand, the heart does not like much volume during pregnancy because of the ventricular compliance, which is low. So these are the conditions where cardiac failure needs to be monitored during pregnancy. Most important is to rule out the cardiac cause for cardiac failure, and then to monitor heart failure. Fetal echoes are repeated during pregnancy. Arrhythmias, as we understand, what we can see here is that grossly the heart is beating so fast. This is tachyarrhythmia. Tachyarrhythmias are actually much more commoner than bradyarrhythmias, and it can happen in approximately 1% of all pregnancies. The fetal echo is done first of all to rule out structural heart diseases, which can happen in up to 10% of arrhythmias. Extrasystoles are much more commoner and more benign than tachy and bradyarrhythmias. And the associated structural heart diseases vary. When we see a tachyarrhythmia, it is lesser, but when we see a bradyarrhythmia, associated structural heart diseases are much more common. So with congenital complete heart block, you can have associated structural heart diseases in terms of heterotaxies or sometimes corrected transpositions, whereas when we have tachyarrhythmias, we look more commonly for diseases like Epstein's or sometimes cardiac tumor or even myocarditis. And whenever there are arrhythmias, overall we know that there are high chances of fetal distress and the mortality is more. One important understanding is when we have a congenital complete heart block with a heart disease, the mortality is extremely high, closer to 100% when we have especially AVSDs with congenital complete heart block. And tachyarrhythmias, once we pick up, And once we start managing in terms of maternal therapies, again once in a week or sometimes even once in 72 hours, monitoring is important in fetal life to see the response of therapy and also to monitor for any onset of hydrops. This is an important understanding to know what is the yield of fetal echo. So if we go through systematically all the indications of fetal echo which were listed in the previous slides, what are the chances that we will pick up a CHD in total? That means that 20% more, the diagnosis of CHD is established in 20% of the cases referred for fetal echo. This means that only 20% of the cases in general are picked up after a fetal echo is referred based on the indications. However, amongst these individual indications, it has been seen that if you have an abnormal cardiac screen on anomaly scan, the yield is huge. And there are certain other indications where also the yield is significant in terms of up to 50% when you have an extra cardiac or a chromosomal abnormality. So yield of fetal echo does vary with the individual indication, but on an average it is around 20%. Whereas there are certain indications like diabetes, or as we discussed, isolated echogenic focus or single umbilical artery, where the yield is much lesser. And hence it's very important to pick up an abnormal cardiac scan during anomaly scan so that we can pick up maximum congenital heart disease. Now the other way, if we include every single indication and then refer it for a fetal echo, only 10% of the cases of total defects will be picked up. So this is a very little percentage of total congenital heart diseases which will be picked up. So then the question comes that, should we do a fetal echo for every single pregnancy? Not really, because as we understand that screening all the pregnancies, it involves a lot of expertise, time and cost. And hence doing every single pregnancy is not going to be practical for us. On the other side, we are going to pick up only 10% of the congenital heart diseases if we limit ourselves to risk pregnancies. So what is the most important messages? That screening ultrasound is an effective tool to identify fetuses that would benefit from fetal echo. Screening ultrasound means what? We initially had an understanding that basic scan, which involves a 4-chamber view, if it is done, is sufficient. However, it has been found that a 4-chamber view will pick up only 60% of the congenital heart diseases. And hence the concept came of an extended basic scan where we include the outflow tracts also and sometimes the 3-vessel view. Now the details about how to pick up an outflow tract, how to do a 3-vessel view, we will see in the subsequent lectures. But for now, it is important to send a message that extended basic scan would pick up 90% of the congenital heart disease. So this is an important take. And every single anomaly scan should have an extended basic scan also as a part and a parcel of the overall anomaly scan to pick up a huge number of congenital heart disease. So this was the take-home message from our lecture. I think we will end our talk session today. Any questions, feel free to communicate.